Okay, thank you so much, everyone, for that was amazing HIV Grand Rounds. And we're now going to transition into our first of the year Center for AIDS Research seminar. Actually, after this particular seminar, all the CFAR seminars this particular year will be online, will be virtual for a variety of, will give us her talk and then introduce our keynote speaker for today. So I want to introduce you to Dr. Allison Comfort, who's an assistant professor at UCSF in the Department of Obstetrics, Gynecology, and Reproductive Sciences, trained as a health economist, PhD in health economy, but what she specifically works on is using social networks analysis. Carol Camlin is involved in this, in all of these projects as a mentor to, for example, increase HIV testing rates among HIV exposed infants in Uganda, also works on antenatal care, contraceptive awareness, contraceptive uptake, and other reproductive aspects of maternal health. So thank you, Allison, for your talk and then for introducing our keynote speaker from South Africa, Dr. Andrew.
So thank you so much for having me today. I'll be presenting on the role of health networks in disseminating knowledge about early infant testing in rural Uganda. And I actually just returned, I was living in Uganda for 2 years, implementing this and other research. So I'm thrilled to have this opportunity to present it to you. I just want to start with acknowledgements. There's a lot of people involved in this work, and I especially want to recognize my KO1 mentors. So Dr. Cynthia Harper, Dr. Carol Camlin, and all right, Dr. Carol Camlin, and then Dr. Ted Ruel, who've been instrumental here at UCSF in mentoring me. This is my KO1 research. I didn't mention CFAR here, but they are funding some of my other social network research, so I'm really grateful to CFAR as well. And then I just wanted to recognize the HopeNet study participants and the HopeNet research assistants for their valuable contributions to this work. So more than 1 million infants are exposed to HIV in high-burden African countries, and every year there's around 150,000 new infant HIV infections. We know that early testing and linkage to care can really reduce mortality, but our challenge is that only 60% of infants exposed to HIV are getting tested as recommended by 6 weeks of age. So that's where my research is focused. Several maternal characteristics are associated with delays in infant testing, but very few studies have focused on maternal and caregivers' knowledge about the timing and how frequently infant testing should take place. And then there's even less research looking just more generally at general population knowledge about early infant testing. So I want to look at this within the framework of social networks. We know that social networks can be important information sources about health. And when I talk about social networks, we mean the social ties people have to, for example, their partner, other family members, friends, neighbors, and others in the community. So this is just one example of what one person's social network looks like. So they're the person in pink. They have 3 family members in their network and then 2 friends. So everyone's social network will look different depending on who is in that network. We also know that individuals often prefer relying on close, trusted social ties to obtain health information and advice, as opposed to, for example, going to providers. And this is also true for women living with HIV. So this is why it's important for us to understand the general population's knowledge about infant testing, since individuals really do sometimes prefer relying on their social networks to get that information. So my research question is, are individuals' social network characteristics, the network composition and structure, is that associated with individual knowledge about timing of early infant testing? And so the composition of the network will vary by person, how many people you have in your network who know about early infant testing, how many people living with HIV are in your network, and then the structure of that network will vary. How big is that network? And then globally, how central are you in the network? Are you very central with lots of ties, or are you more on the periphery of that network? And all these factors may matter for your knowledge about early infant testing. So in terms of our methods, we collected sociocentric network data from all adults in Nyakabare Parish in Uganda. So when I say sociocentric network data, that means we're gathering data on people's relationships And because by virtue of collecting data from the full population, we essentially have a map of all social connections in the entire parish. So how do we do this? We use name generator questions to gather information about their health work. So our question was, over the past 12 months, with whom in this parish have you usually discussed any health issues, for example, related to your child's health, HIV, family planning, et cetera? And so they name all the people they turn to. And then for each person they name, we have these follow-up questions. So say they say, well, I turn to Fiona. And so we ask some more questions about Fiona. How frequently do you see her? How much do you trust her? So we have all this data on the individual participant and then all their social ties. And then in a separate part of the survey, we ask about their own knowledge about infant HIV testing. Do they know if infants exposed to HIV should be tested, and at what ages should they be tested? And so we know this for the study participant and knowledge about if their social ties also have this knowledge or not. So for our analytical approach, our primary outcome is a binary measure for whether the study participant knows that infants exposed to HIV should be tested by 6 weeks. And then our predictors are various measures of network composition. So for example, how many social ties also have correct knowledge about early infant testing? How many people in their network are living with HIV? And then network structure measures. Degree is the size of the network. Eigenvector centrality is how central, one measure of centrality of how central they are in the global network. And then our models adjust for other sociodemographic covariates. And we use a generalized linear model with a logit distribution and cluster standard errors at the village level. So our results, this just gives you a brief idea of our sample. So about 50% are female, median age is 40, and about 11% report living with HIV. So this gives you one idea of the network in one of the villages among the women. So in light blue are those who are HIV negative, and darker blue, HIV positive. And you can already kind of see that the women living with HIV are already a bit on the periphery. And then I've sized the nodes based on how many people they turn to for health advice. So bigger nodes is you turn to more people. So it's just that you can visualize with different characteristics of the network. So now in terms of our outcome, we see that 78% know that infants exposed to HIV should be tested by 6 weeks. So about 20% don't know that they should be tested by 6 weeks of age. And then within their networks, we see that 78% have at least one social tie who also knows about early infant testing. And here, if we look at the number of social ties who have this knowledge, 22% have no one in their network that knows this. Most of them, about 45%, have one social tie, and then about 30% have 2 or more people in their network who know about early infant testing. And then the size of the health network is about 4 people. You can see trust is relatively high. It's 8 on a scale of 1 to 10. And then about a quarter have at least 1 or more people in their network living with HIV. So these are our model results. Again, the outcome is not having knowledge of early infant testing by 6 weeks. This first result shows that the size of the network is not predictive of knowledge of early infant testing. But what we see here is that having at least one person in your network who knows about infant testing is associated with significantly higher odds of the individual also knowing about early infant testing. Here we see there's not this linear relationship, so it doesn't matter if you have 2 ties versus 3 ties who knows it. So what it's showing is it's really this threshold effect. People need at least one social tie. You don't need 2 or 3, but you need at least that one person in your network who knows this. And then interestingly, the number of people living with HIV in their network is not predictive of knowledge of early infant testing. So in terms of our findings, overall we're showing that it's essential or critical for individuals to have at least one close, trusted social tie who knows about early infant testing. But the other characteristics of these social ties, such as their serostatus, their gender, age, are not predictive of knowledge. It's really having that one person who knows about infant testing. And so what this means when we're thinking about interventions is when we're implementing, for example, a health education campaign, we should be educating people about early infant testing, but really encouraging them to also share that information with their peers and peers regardless of serostatus, since we need to educate the general population about this and that's who people want to turn to, their close social ties regardless of serostatus. Another approach is to identify these highly connected individuals in the network. So find the nodes that a lot of people are going to for health information, educate them, make sure they know about early infant testing, and then encourage them to disseminate that to their close social ties. So thank you very much. I think I have time for one question because we have to make, yeah.
I'm not usurping someone else's question. Allison, thank you for this great talk. I'm really interested in trust, and your data may not have permitted this, but was it possible to look at for people that do have one or more social ties that are not as trusted, have a lower trust score? Was there the same finding? Were you able to, is it possible to do that?
So it was possible, and we collected that data. Here, I just use the name generator for health networks. And when I just look at the health network, I don't see a relationship between trust and the outcome. What I think, when I talked a lot with the research assistants about this, I think it's that they're already selecting their really trusted people to be in their health network. I think, I haven't looked at it yet, but if I look at the whole social network, that includes others, like people you share meals with, people you spend leisure time with. Yes, so I think I might see it. There was something I wanted to do is look at trust in that bigger network, and maybe we'll see it come out. Because I think this health network is a really selected sample of, these are the most trusted people in my life that I'm okay sharing these really yeah. And we're seeing really high trust in those people. Yeah. Okay, thank you so much. So now, I don't know if or the slide. Oh, okay, it's consistent. Okay, perfect. So now I have the pleasure of welcoming Dr. Andrew Medina Marino, who's our main speaker today. He's a molecular biologist and field epidemiologist. He's the principal investigator at the Desmond Tutu Health Foundation in Cape Town, South Africa. He's also an associate professor at the University of Cape Town's Desmond Tutu HIV Center, and also an adjunct associate professor at the University of Pennsylvania's Perelman School of Medicine. He completed his PhD in molecular neuroscience right nearby at Caltech, and he's had a fascinating career trajectory. He first started at CDC as an epidemic intelligence service officer, where he received the Donald Mackel Memorial Award for successfully exemplifying how to combine epidemiological and laboratory approach to an investigation. Then he moved to South Africa in 2011, where he first worked as the senior technical advisor for disease surveillance and laboratory system. And during that time, he twice was called to assist with the Ebola epidemic in Liberia. Now he's as a founder of the Desmond Tutu Health Foundation, he leads the NIH-funded D43 PhD training program in partnership with the University of California's Global Health Institute. His research focuses on HIV and TB-related care seeking. So one of his studies looks at integrating STI screening and treatment during ANC visits for pregnant women living with HIV. Another is focusing on acceptability and feasibility of home-based TB testing using a new mobile point-of-care technology. And today he'll be sharing his NIH R01 study. The title of his talk is Leveraging Community-Based Platforms to Improve Access and Adherence to PrEP, the Community PrEP Study. So please join me in welcoming Dr. Medina Marino.
Good morning, everyone. Okay. Just want to keep myself on time. I know folks are busy. Okay, so first off, thank you very much for inviting me to give this talk. I'm going to tell you about some of our work that we actually started quite some time ago. It was impacted by COVID, so sometimes the data wasn't always the best. Let me, just to get started, let me just give you a quick overview of South Africa. So I know many of you work in South Africa. This is just the 9 provinces in South Africa, and I'll explain why I'm putting this up. So just for some quick overview. Okay, so we know South Africa has the largest HIV epidemic in the world. The general population prevalence right now, based on the Tembisa model, is about 12.6% for general population. Prevalence amongst those 15 to 49 years is significantly higher. In terms of the 95-95-95 cascade, South Africa has about reached the those who should know their status. Those who are on ART is about 78%, and those with a suppressed viral load is sitting around 73-74%. Uh-oh. Here we go. Okay. So we know that the prevalence of HIV in South Africa and where the density of individuals who are living with HIV is definitely not distributed equally around the country. In the first panel, you see the prevalence, and what you see is the majority of the prevalence is sitting on the eastern part of the country, mainly focused around Gauteng, KwaZulu-Natal, Eastern Cape, and Mpumalanga. And where in the second panel, you see the density of those living with HIV between age 15 to 49. So the reason why this is important is, so when you think about the historically advantaged research centers in South Africa, you're usually thinking Durban, Johannesburg, Cape Town, but there's a huge prevalence of disease in Eastern Cape. Specifically, so unfortunately, Eastern Cape has the lowest human development index score of all 9 provinces. It's been that way since about 1995. The prevalence of adults is 3rd highest in the country. The TB prevalence is hands down the highest in the country. It has some of the poorest metrics for HIV, TB, maternal child health, mental health, health service delivery, and unfortunately has a very poor research infrastructure compared to the historically advantaged centers in Durban, Johannesburg, Cape Town. So back in 2021, we decided to start a new site in Eastern Cape. So specifically, the goals of this site are to ensure that the voices of citizens and communities in Eastern Cape are heard in regards to global TB and HIV research, that key public health research is conducted to provide targeted interventions in those communities, and also obviously to provide provincial data for resource allocation. Now, a big thing is, when you think about, the FemPrep and voice trial, those were all done in where? Durban, Johannesburg, Cape Town. And so you typically never have heard the voices of communities in Eastern Cape amongst these kind of global programs. So just to give you some a quick graph of incidents, this is produced by the Tembisa model. So this is South Africa nationally from 1987 to 2023. And then you see those typically historically advantaged provinces, their incidence curves. And what you see in Eastern Cape is actually Eastern Cape is starting to become the highest incidence province, but there's typically been the lowest amount of HIV prevention research conducted in the province. So the ECHO trial, which looked at contraception HIV outcomes, they did a number, this was back in 2015 to 2018. And the incidence for HIV amongst the sites was approximately 4.5 cases per 100 women years. And the incidence for all the sites was greater than 3. Now, the key thing is in Eastern Cape, it had the 2nd highest incidence recorded of all the sites in the ECHO project. And that was about 5.37 cases per 100 women years. So we know that there's a large number of barriers that adolescents and young women face with regards to accessing health services in clinics. So these could be things about around societal and provider stigma and around their perceived sexual behaviors, lack of adolescent-friendly services. There was a large program about a decade ago that was trying to scale up adolescent-friendly services. Unfortunately, that has not fared very well, and it's not been very sustainable. Obviously, there's also some structural issues around access to clinics, the timing of clinics, the distance to clinics, very typical things. Real or perceived lack of privacy in these clinics for adolescent girls and young women. There's also been a general lack of knowledge about what things could be accessed at these clinics, especially around health reproductive services. So given the high incidence of HIV amongst adolescent girls and young women and the issues around their barriers to accessing clinic services, we were trying to think about is, look, what could be potentially some of the some of the community-based services that could be provided? How do you leverage community-based platforms to provide access to PrEP? So how did we actually get to trying to leverage community-based platforms? So about a decade ago, I was involved in one of the largest community-based counseling testing programs. It was funded by PEPFAR, and it was conducted in a number of the highest burden districts throughout South Africa. There was only one district in Eastern Cape, even though some of the highest burden districts still are in Eastern Cape, for whatever PEPFAR reason that was. So between 2016 and 2017, this program had conducted more than 500,000 HIV tests in the community. And this was open to all individuals in the community. There wasn't necessarily a targeting of adolescent girls or young women, but what we saw here was, and I'm sorry, some of these slides don't necessarily look the way I developed them, but what we saw was hands down the age groups of 15 to 19, 20 to 24, we saw the highest number of young women, we saw the highest number of testing being conducted and provided by to adolescent girls and young women. And again, there was very little, if any, really direct targeting of HIV testing services to these adolescent girls and young women. So the fact that we saw the highest uptake amongst these two age groups by young women really was telling us, okay, community-based testing was very accessible and acceptable to them. And so then this got us thinking, okay, what are the potential implications for these of leveraging community-based testing platforms for providing PrEP to adolescent girls and young women? So we know that there's a number of gaps for accessing and providing access to PrEP. So things around access of PrEP to those who are at high risk, identifying individuals who are at high risk, screening individuals who are at high risk, linkage to these kind of PrEP programs, which have typically been and continue to be overwhelmingly in the clinics, the prevention, effective use and adherence of PrEP, and the retention in PrEP services. So when we think about potential synergies for community-based platforms, community-based HIV testing platforms for access to PrEP, we really think about identifying high-risk individuals, especially adolescent girls and young women in South Africa, screening of those high-risk individuals with HIV testing, and linking those individuals to PrEP programs, especially if they're co-located in the community with these testing platforms. So this is where we come into the community PrEP study. So there were three main aims of the study. The first one was really to look at the acceptability and feasibility of leveraging community-based testing platforms for providing access for PrEP service to adolescent girls and young women. The second one was to evaluate a behavioral intervention to support the prevention effective use of PrEP. And the third aim was to do a cost effectiveness analysis of this work. So the two main aims that I'm going to talk to you about today are the first one, which is the acceptability and feasibility of leveraging this platform, and the outcomes of the behavioral intervention. Okay, so the first aim was a cross-sectional study was conducted amongst adolescent girls and young women age 16 to 25. In terms of the type of community-based testing platforms that were set up, it was pop-up tents or specifically systematic door-to-door home-based testing. This was conducted between October 2018 and November 2019. And the primary outcome was the proportion of young women accepting PrEP as part of community-based testing. So we had a stepped enrollment procedure here. So obviously, adolescent girls and young women or anyone in the community was able to present to the testing site to be eligible for a baseline questionnaire that would look at a few things around interest in PrEP uptake. Those young women who are HIV negative, who self-identified as female, and who are age 16 to 25 were invited to take this baseline survey. Part of the baseline survey, within that survey, was a PrEP video, information video that would provide some basic information to determine if they were at least interested in learning more about PrEP. For the purpose of time, I won't go and show the video. So the second part was if a young woman had said, after watching the video, yes, I'm interested in learning more, or I'm specifically interested in taking PrEP, they would be considered eligible. They were then given a referral for the PrEP service site. So if we were conducting home-based testing, young women would be given a referral to a PrEP service site that was part of the study, which was usually maybe 1 kilometer or 2 away from their home. For those who are accessing services at a pop-up tent, the PrEP services were literally co-located with that HIV testing. So it would be maybe 10 meters away at most. In terms of exclusion criteria, so at the time, the South African guidelines didn't permit the enrollment of women who are already pregnant, but it changed during the study. And so women who became pregnant while they were part of the study, we kept them in the study. So one of the big things about the study, at least at the time, was many previous studies were using some sort of risk assessment tool to determine eligibility. And we said, unfortunately, being a young woman in South Africa, especially in townships, probably provides all the risk you need, unfortunately. Okay, this is definitely not the slide I originally had. Is it possible to try and fix these at all? Is there like a rendering? That looks better. Much better, okay. Now it's much cleaner looking. Perfect. And this works again. Okay, so as part of the study, we had tested about 1,100 young women. Of those, we had a positivity of about 4.6%. For those who were considered eligible for referral for the study, there was about 22% who said they're just not interested at all in engaging in any study. So at this point, they had not heard anything about PrEP. So this 22% is not a lack of interest in PrEP, it's just a lack of interest in engaging, period. So 71% were referred for the baseline survey, and of those 825, 806 were referred to PrEP services. Now, of those, there were only 4 young women out of the 19 who were not referred, who just said, I'm not interested in PrEP. So there was obviously a big interest in PrEP, at least through this program. The total number who actually presented for services was 77% of those referred. The total who consented was 99% of those who presented for learning more about the study. And we ultimately started 603 on PrEP. I should specifically mention that because we were referring young women from the pop-up testing, which was literally, again, just a few meters from where PrEP was being provided, versus the young women who were tested in the home and referred to a site. So nearly 100% of the young women who expressed interest and referred that were part of the pop-up testing actually presented for learning more and trying to initiate PrEP. But only about 44% of young women who were given a referral from their house and had to go, half a kilometer to the PrEP service sites actually presented for services. Now, the nice thing is, of those who actually presented for, hey, I'm interested, let me hear more about the study, 99% of those young women actually initiated. Okay, so just some very quick descriptive stats about the study. So this was a population of young women who were highly sexually active. There was a difference between the urban and rural areas. In terms of their last sex act, about 50% had had sex or self-reported having sex within the past month. In terms of the frequency of condom use, unfortunately, it was very low. It was about 20%. We didn't necessarily do qualitative work to understand what the issue around this was, but it probably has to do with also, the ability of young women to make decisions around using condoms during sex. In terms of ever having it been tested. So obviously there's been a massive amount of HIV, community-based and clinic-based HIV testing performed in South Africa. So as you can see here, more than 90% of young women had ever been tested before. So this is a very highly tested population of young women. In terms of the number of times they've been tested, more than 50%, almost 60% had been tested more than 3 times in their life. And then since the last time they were tested, less than 3 months, they had received, about 40% had been tested within less than 3 months before. In terms of the perceived HIV risk of these young women, in terms of their self-reporting, it was on a scale of 1 to 10, and virtually all of them, the median was a score of 1. In terms of STIs diagnosis part of the study, 38% of these young women reported had a detectable STI using a vaginal swab. So unfortunately, a very high but not unexpected proportion had STI infections. Now, the issue here is that of the 179 participants who ever reported having sex, of the 179 participants who reported never having sex, 31% of those had a detectable STI. So again, the self-reporting nature of this, when you think about these kind of risk assessments, when it's self-reporting, it's not going to work. And this is a perfect example. In terms of the 120 participants reporting that they say they always use condoms, 34% had an STI. So again, a self-reporting issue. And of course, that's part of the limitation of why we should not be using these kind of risk assessments, especially in populations like this. So when we look at the time to PrEP initiation from the point of referral, so of those young women who were provided a referral when they were tested at the pop-up site, 100% of them who were initiated the same day that they were given the referral. Why? Because literally it was walk 5 meters over and there it is. In terms of the young women who were provided a referral from their home to accessing the services in the community, it ranged from same day to as far out as a little bit more than 32 days. So we decided to look at the factors associated with influencing time to presentation for PrEP services. And unfortunately, through all the variables we looked at, we didn't necessarily find anything that seemed to be statistically significant, but we did an overwhelming amount of qualitative work to really try and understand what might be going on. And for those young women who are considered to have immediately or delayed presentation to the clinic, to the study site, those who immediately presented, so within 3 days, they described their HIV risk as high. They also they already had some knowledge or were aware of PrEP beforehand, and they had also reported positive familial support. So I should mention, this is specifically of young women who were referred from their household, because all the young women from the co-located testing site started the same day. In terms of those who had delayed presentation, so anything after 14 days, what we saw was those who had delayed presentation described their HIV risk as moderate. They did not feel that they had enough information about PrEP, and they wanted to have more information before they presented to the site. And they also had reported some hesitancy or overcoming some hesitancy from some of their concerns because they had received encouragement from family. And this was specifically young women were talking about less about their mothers, but more about their aunties, where they spoke to their aunties about support. And the aunties were the ones who were saying, you should go at least hear about this. For those who never presented to the site, they described themselves at low risk for HIV. And they had also they were also expressing concern about any disruptions to their relationships and also concerned about experiencing stigma or judgment for accessing PrEP. So in terms of how quickly young women, after they were given their first bottle of PrEP, returned for their first refill, we looked at how many young women presented within at least 90 days. And we saw only about 54% of those who ever received a second bottle or a first refill bottle presented within the first 90 days. Okay, so let me tell you a little bit more about the second aim, which is around the behavioral intervention. So this was a 3-arm randomized control trial. The study arms were being provided adherence support in a one-on-one fashion. The second arm was around receiving adherence support and empowerment in a group setting. And the third arm was just a basic community pickup point for accessing their PrEP. And the primary outcome was measured tenofovir in their blood. So let me tell you a little bit quickly about the actual behavioral intervention. So this was informed using the information, motivation, behavior skills model. And obviously what we did was we mapped onto those different components and aspects of the behavioral support intervention, the empowerment intervention. So there were 2 parts to this. There was when young women came in either for their one-on-one or their group support, they always got a PrEP check-in. I'll tell you what that's about now. And then there were session-specific sets of topics that were also discussed, and I'll explain that to you a little bit more. So in terms of the PrEP check-in, so this was really about checking in with young women about how their last month has been or since their last PrEP pickup. They were asked constantly about any potential side effects, both physiological side effects and social problems or adverse events. We asked them about how it might be impacting their relationships or any changes in risk that they may have experienced in the past month or again since their last PrEP pickup. With regards to life skills, so this was So the different topics that were part of this set of life skills that were provided were things around incorporating PrEP into their daily lives, talking to people and disclosure support around their PrEP use, problem solving around any challenges that might have come up around their PrEP use. There were also things around, how to develop a CV, job postings and supports. Let's see. That for now. Okay, so in terms of the randomization, so of the 603 young women that were recruited into the study, there was an appropriate allocation. When we looked at all the participant characteristics, they were well balanced. There were no major statistical differences between the arms. One thing that we did notice was gonorrhea seemed to be higher in the 2 intervention arms than in the control arm, but all other variables seemed there were no significant differences. So in terms of returning for at least 1 refill, so the way we had actually calculated the sample size was not, or the size of the sample to be used for the primary outcome. It wasn't just about recruitment into the study. It was young women had to have returned for at least 1 PrEP refill, because the idea of receiving the behavioral intervention, if they never returned, they never received the intervention. What we did look at also was, were there any characteristics that seemed to be different between those who returned for at least one PrEP refill and those who never returned for a refill? And for all those, we didn't see any significant difference between any of the variables that we looked at. What we did see was we saw a very large drop off in the number of PrEP refills that young women actually came back for. So in terms of this 88, this was how many young women came back for one PrEP refill. For 37 was 37 came back for 2 PrEP refills, and all the way down through only 3 young women actually came month to month for the 2-year follow-up of the study. So again, we did a large amount of qualitative work, and we were looking at the factors that influence PrEP discontinuation or reinitiation, because one of the things that is not necessarily seen on this graph is there's a large amount of a large amount of start stopping that we saw in the study. So we wanted to really look at, so what were those at least qualitative factors that seem to be important in if a young woman did not come for PrEP for at least 2 to 3 months, them either reinitiating, or for those who never came back, we were also able to identify them and speak with them. What we saw was adolescent girls who frequently missed PrEP doses cited a lot of changes in their life, traveling, and this led to inconsistencies in their ability to retain access to PrEP. So a lot of young women were moving around in between townships from a more peri-urban to some of their rural homes in their families. One young woman had specifically said, a person's routine changes and they don't wake up at the time that they usually do when they are going to school or when they're on holiday. They won't take their pills with them because they did not tell other people in their family about their PrEP use. One of the big things that young women who seem to reinitiate after having a period of stopping PrEP, or at least not coming to pick up their refill, was around encouragement from their family to come back and get another bottle of PrEP. And one young woman said, what influenced me to come back after I missed taking pills was because I was not comfortable now with my boyfriend. I was then lucky again because he influenced me. He kept asking, are you still picking up your pills? And what we did see a lot of times was young women talking about changes in their relationships and having a new boyfriend, or inherently not trusting their boyfriends or men in general to either disclose their HIV status or to tell them if they're sleeping with other women. With regards to those young women who had actually, never came back for a PrEP medication after we had noticed them stopping for a minimum of 2 to 3 months, one of the big things was around behavioral scrutiny or judgment from family and friends, or their partners not being supportive of them, inherently being, not trusting them. And one of the big things was we constantly kept hearing young women saying, my boyfriend thinks that I'm sleeping with other men because he keeps telling me that he's negative, but I still don't trust him. So again, issues around partner mistrust. Okay, so one of the things we also did was, between the 2 intervention arms, we looked at the difference, if there were any significant differences between those 2 intervention arms before we compared to control. And part of it was so that we could, if there were no differences, we would be able to combine those 2 intervention arms into one to give us a little bit more power for our analysis. And what we did find was there was no significant difference in any of the characteristics that we looked at between the 2 intervention arms. So that allowed us to inherently do an analysis of intervention versus just a control. So we had done some logistic regression models, and we looked at time effects and differences between the control and intervention arm. What we saw was that there was no difference in the probability of young women presenting for a refill. And the reason why, even though I had originally said we were looking at tenofovir blood concentration levels, because the amount of drop-off, the amount of data that we had for the blood concentration wasn't enough to really give us any power. And so we looked at refill pickup because we have obviously had a lot more data on that. And even when we look at refill pickup as a as an outcome, we didn't see any difference between the intervention or the control arm. So unfortunately, it looked like the intervention had not worked. But what this did allow us to do was it allowed us to use the entire study cohort, the entire study population as a single cohort. And what we did from there was we did some trajectory modeling to see where their unique trajectories for or patterns of refill behaviors. And what we found was in panel A, the green top line is those young women who were very consistent in remaining on PrEP or continuing to come back for PrEP refills. The red line are those who started to come back but very quickly dropped off. And the blue line was those who within a month or two, they stopped coming altogether, period. So we identified 3 trajectory groups in terms of patterns of refill accessing. So we were trying to understand why didn't this intervention work? And again, we looked to a lot of the qualitative work we were doing. And the control arm where it was community pickup. So the community pickup was still our study staff. And the young women in that arm were still able to passively speak with the nurses who were providing PrEP. And they were still able to passively access support from our staff. And what we were finding was we thought it was control, but it was a very active control. And so what we found a lot of young women actually saying in both the control and the intervention arms was inherently the control received so much support and felt so welcomed that we feel that that may be an explanation potentially why we didn't see any effect of the intervention. So the last thing we did was also look at post-study uptake, where those young women who were completing their 24 months, we provided a referral to the local clinic. And we broke this down into 3 groups: those who presented to a clinic and continued to take PrEP, those who presented to a clinic and decided to not continue PrEP, and those who just, at least at the point that we spoke with them, had not yet gone to the clinic. And for those who actually went to the clinic and continued taking PrEP, one of the big things that they were saying was they had already had experience with accessing services, sexual reproductive health services at the clinic. So even though they recognized a lot of the issues and barriers at the clinic, they felt still more empowered because they knew how to navigate the system. They also were talking about how they continue to value the type of prevention that PrEP was providing them. And they spoke about, providing me protection if I'm raped, providing me protection because of low trust in men to disclose their HIV status or if they're sleeping with other women. For those women who actually went to a clinic and they decided to stop taking PrEP, they were discussing the types of barriers that seemed more impactful for their behaviors. So things around long wait times at the clinic. We had a number of young women talking about being turned away from the clinic because at this point, a lot of these clinics were only having one nurse who was acting as a PrEP champion. And so if that nurse wasn't around, there was no PrEP given out that day. And so they just felt very disenchanted with the system. And a lot of young women were also talking about knowing that when they went to the clinic, they weren't going to receive the same type of support that they felt that they were receiving from our study site. In regards to those women who had said, I'm potentially still interested, but I haven't gone to the clinic yet, one of the big things was women were reporting that they still had PrEP left over from the study, which definitely spoke to the issue of stockpiling. They also spoke about logistic barriers in terms of schedule conflicts, especially if they were younger and still in high school. And they were also fearing the typical kind of barriers around judgment of the clinic staff, stigma, and not having the same type of support from our study staff. Okay, almost done. So I just want to give you some quick highlights about the new DTHF site in Eastern Cape. So the site started in, well, the site didn't start. We started doing projects in collaboration with other local partners there in 2017. This is when the community PrEP study had started. We officially said, okay, let's put down roots here in January 2021. And then between January 2021 to about today, it's grown from 2 individuals to about 75 staff members. So it has grown very quickly in a way sometimes it feels like it's breaking at the seams. It's exciting, but it's a lot. So in terms of the research focus areas of the site, so the 2 populations that we really focus on are adolescents and men. With regards to TB, there's a lot of work going on around new diagnostic evaluations, community-based case finding activities, improving access to prevention services, providing or developing interventions and evaluating interventions specifically around supporting men to stay retained in care. And for any of you who I speak with afterwards, I'm happy to tell you about some of our work on that. And with regards to HIV, it's obviously very heavy HIV prevention, and then also treatment support to reach viral suppression. There's also been a strategic decision to start laying down clinical and diagnostic trial infrastructure. So at one of the largest community health centers in the area, we've laid down a few containers that have consultation rooms, and we're building up a diagnostic lab there. We also have the famous Tutu tester in Eastern Cape. And this is actually currently implementing a study called Mobile Men, which is providing men who are mobile, which is a very large definition. You could probably drive the Tutu truck through it, for providing access to either injectable or oral PrEP, and to look at issues around preference. And that is it. Thank you very much. Any questions? Go ahead, Monica.
So,
right on time, 36 minutes. Okay. Perfect.
So what is it sounds like you didn't talk on the TB studies that you've been doing.
Yep.
That you have and you're working on TB.
Yep.
To see, is this site also, you really convinced me when I went there that Durban, Johannesburg, and Midtown get all the funding, but these rural areas is what, where the prevalence is so high. And so talk about the TB, if you could just talk a little bit.
Oh, happily. So we have three NIH grants focused on TB. One is around looking at HIV and TB intersectional stigma and other social determinants on people's progression along the TB testing cascade. So starting off with active case finding, are people presenting to the clinic? What's the impact of stigma or other social determinants on presenting from households to the clinic? Those who passively present to a clinic for testing, coming back for their test results, looking at stigma and other social determinants on starting treatment and progressing to successful treatment completion. So there's a lot of stigma work and social determinants work around TB. There's another one that we're doing around TB and mental health, where we're looking at a intervention for interpersonal counseling to deal with those with TB and comorbid depression, to look at if we address the depression, how does that impact successful completion of TB treatment? We have another study looking at supporting men to stay retained in TB care and services. So there's a program called the Coach and Pilo program. It was developed for men who are HIV positive, for men who are HIV positive, as a peer support intervention for men with HIV. And we have adapted that for men with TB. And we had another NIH grant that really did a lot of formative work around what are men saying that they want and need in terms of TB support intervention. And when you look at a lot of the interventions out there, men were saying they want an intervention that is not clinic-based. They want an intervention for support delivered by another man who had previously had TB. They want an intervention that is delivered to them where men are congregating. And when you look at, there was a great systematic review meta-analysis that came out of an individual at UCSF that looked at adherence interventions. And when we did a deep dive of that paper, and we looked at all the interventions that they were covering, not one of them spoke to what men were actually saying that they wanted and needed in terms of pure support, delivering of an intervention to men in male-oriented spaces. So we adapted this Coach and Pilo program, and it's R34, looking mainly at acceptability, feasibility. Hopefully it'll be good enough. We'll apply for an R1 in a few years. And then we also have another study where we took a GX1 device, hooked it up or jerry-rigged it to a car battery and brought it into people's homes to test for TB in the homes, because we know that when you go out into the community and you refer people from the house to the clinic, maybe 15% of individuals present to the clinic. So we did that study, but now we're applying tongue swabs, because obviously we know that a large number of individuals with or without symptoms can't produce sputum. And that one is showing some pretty exciting results. I won't go into all the results, but they're very exciting. Yeah, so there's a lot of TB work as well going on.
So thanks for presenting the results of a study that ostensibly maybe one could say had negative findings, but so much was learned by it. And so what are your reflections on what can you pull out of that study that is most relevant for the era where we have both injectable and pills? Because certainly some stigma is overcome, but not all the obstacles that all of us working in this field that you so nicely outlined exist.
So your question is reflect on the fact that there's all these new injectables. How do we potentially leverage this platform for something like that? Is that what you're asking?
What did you learn from the barriers that are still going to exist?
Yeah. Okay. So injectable is great. It's not going to be accessible in South Africa for quite a long time. So oral PrEP is still going to be pretty much the only game in town. So still figuring out how to support young women to effectively use PrEP is still going to be something that needs to be looked at closely. Probably one of the big reflections is maybe adolescent youth-friendly services is actually overwhelmingly what is needed, and not all of these, trying targeted behavioral interventions. Maybe if you just have good support for adolescents, that will overcome a lot of the barriers. I think that's a big thing to take. And obviously that's probably been in the general knowledge or thought for quite a long time. But unfortunately, I think a lot of countries still don't get right adolescent youth-friendly services. Another thing would probably be, at the time that we conducted this study, at least in Eastern Cape, they were still rolling out PrEP. So PrEP was only rolled out in Eastern Cape around 2019, which definitely, again, speaks to the fact that, well, in Durban, Johannesburg, Cape Town, when they rolled out these studies back in 2009, communities had access to that, whereas communities in Eastern Cape had access only a decade later. Might be a small targeted access, but it's still access nonetheless. So I would probably say another big thing is doing a lot of community awareness around PrEP, because one of the big things that young women were talking about was having support from family or friends. But at that time, a lot of family and friends hadn't heard of PrEP. So that's probably another big takeaway, that, if we were to do another study like this, we would probably do a heck of a lot more community campaigns around at least PrEP awareness.
Can I just ask one final question? The distrust, so South Africa has a different history than East Africa, and the apartheid legacy is still very much there, and especially in these townships that we went to, and the high rates of unemployment. Is the distrust playing into how much the distrust here, affects different racial and ethnic minorities in this country? The distrust there is so much higher against these medications that are produced by the government. And so how do you combat the fact that there's so much circulating viremia because of distrust in people living with HIV, because they're not taking their HIV medications, and thus the incidence is so much higher? How do you combat that mistrust in your community PrEP program? Because it's a pill.
How do you address mistrust of partners or of the clinics?
Yeah, the trust of the government, the white man's medication, the pill that is made by by the government.
Yeah, I don't think we heard any issues around mistrust of the medication, at least coming from the young women. The mistrust really was around partner mistrust and young women's ability to continually use their PrEP in front of other people. So that was probably the bigger mistrust. Mistrust in the health system. Yeah, that's $1 million question. Let me reflect on that a little bit more and we'll talk later. All good? Okay. Thank you very much.